walks in the door wants a checkpoint inhibitor.
Yeah. Now, I think patients, and we are very excited about the availability of those checkpoint inhibitors. They haven't really shown in gynecologic malignancy the efficacy that we have seen in lung cancer and melanoma, renal cell carcinoma. Nivolumab was the first checkpoint inhibitor that was presented here in ASCO 2014 and discussed this paper at the time out of Kyoto. There were 2 complete responses in 2 clear cell carcinoma, heavily pretreated. So that generated excitement. Pembrolizumab was studied in Keynote 28 as one of the many solid tumors that was treated with single agent pembrolizumab, and did show some signal. And it was particularly interesting to see signals in those patients whose ovarian cancers had PD-L1 expression. Yeah. So Keynote 100 takes it a step further now and really looks at 2 different cohorts of patients with more or less prior lines of chemotherapy, and shows, and we will see this data presented by Dr. Ursula Matalonis tomorrow in the clinical science section, that those patients that have rather high expression of PD-L1 have indeed a 27% response rate. That compares to 14% response rate in the lower expressors of PD-L1, but that's still, I think, fairly promising and better than we have done before with single agent immune checkpoint inhibitors.
And I like to categorize things as a This is a very exciting, evolving field.
Yeah, I'm just to add, I think you're right. I think tumor mutational burden is a readout that we get from our somatic mutation testing that's reported out. I think there is some correlation between tumor mutational burden and response to immune checkpoint inhibition. In lung cancers, that is a stratification idea, and I think we should look at this more in our ovarian cancer.
I think not only selection is important, but also endpoint is important. So response rate is important, but duration of response is really important for these agents.